Welcome back to Radon's Smart Review GI series. This is episode 22, Case-Based Review Lower GI. Today we're shifting gears a bit into a mock oral board examination format. I'm going to present several challenging clinical cases, and we'll work through them together, just like you would during your boards or, frankly, in your everyday clinic. Our goal here is really to solidify your clinical decision-making, apply those evidence-based principles, and, refine your structured approach to complex oncologic scenarios. For those of you listening in, I really encourage you to pause after each question and truly formulate your own detailed response before we jump into the model answer and those crucial teaching pearls. This whole exercise is designed to get you integrating all the knowledge we've built up over our GI series. Ready? Let's do this. All right, let's jump right into your first case. We'll start with what you might consider a pretty standard presentation of locally advanced rectal cancer. Your patient is a 58-year-old man. He initially presents with rectal bleeding. A subsequent biopsy confirms he has a moderately differentiated adenocarcinoma. And importantly, molecular testing shows its proficient mismatch repair, or PMR. His colonoscopy reveals an ulcerated mass specifically located at 7 centimeters from the anal verge. So given this initial presentation, walk me through how you would proceed with his initial consultation and the comprehensive workup.
Okay, yeah, that's a classic starting point for a rectal cancer case. My initial evaluation would be pretty meticulously organized, to make sure we gather all the necessary information for precise staging and to formulate an optimal multidisciplinary treatment plan. First, I would conduct a thorough clinical evaluation. This starts with a complete history and physical, H&P. I'd specifically focus on assessing his overall performance status, probably using the ECOG scale, just to determine his ability to tolerate potentially intensive treatments like chemo and radiation. I'd also, dig into his past medical history, looking for significant comorbidities that might influence treatment choices, and a detailed family history, too, to screen for any inherited colorectal cancer syndromes, like Lynch or FAP, which would definitely warrant genetic counseling and testing.
Right, good points.
Second, a key physical exam component is absolutely essential. The digital rectal exam, the DRE. This is, it's more than just a routine check. It gives you invaluable clinical insights that even fancy imaging can't fully capture. Through the DRE, I can assess the tumor size, its exact location from the anal verge, its mobility or fixation, to surrounding structures, and its relationship to the sphincter complex. This directly informs whether sphincter-sparing surgery is feasible and gives us a clinical T-stage assessment right off the bat.
Makes sense.
Third, for tumor markers and staging blood work, I'd order baseline labs. A CBC, obviously, to check for anemia from the bleeding and assess bone marrow function. A CMP evaluates his liver and kidney function critical for systemic therapies. And most importantly, I'd get a baseline carcinoembryonic antigen, CEA level. While it's not diagnostic, the CEA is a crucial prognostic indicator and, critically, a marker for surveillance after treatment to catch potential recurrence.
Absolutely crucial, that CEA.
Fourth, for imaging for staging, two main modalities are essential. A contrast-enhanced CT of the chest, abdomen, and pelvis is mandatory to rule out distant mets. We're looking for common spots like the liver, lungs, peritoneum. Equally critical is a high-resolution pelvic MRI. The MRI is really the gold standard for precise local staging of rectal cancer. It gives you that exquisite detail on the tumor's depth of invasion, its relationship to the mesorectal fascia vital for predicting the CRM, the circumferential resection margin, and for spotting any suspicious regional nodes in the mesorectum and pelvic sidewalls. Those T2-weighted sequences are particularly useful. And finally, recognizing just how complex rectal cancer management is, I'd initiate multidisciplinary care immediately. Prompt referrals to colorectal surgery and medical oncology. Early involvement ensures a comprehensive, coordinated, consensus-driven plan from the start. It's just best practice.
Excellent. That's a very comprehensive and well-structured initial workup. Exactly the kind of systematic approach we want to see. Let me just add a quick clinical pearl here for your boards. For a new rectal cancer presentation, always explicitly state and justify the 3 pillars of staging. You touched on them perfectly. First, the DRE for direct clinical assessment mobility, sphincter involvement. Second, the high-res pelvic MRI for precise local staging, especially assessing that CRM, which is arguably the most important local prognostic factor. And third, the CT chest, abdomen, pelvis for comprehensive distant staging, ruling out mets. Those 3 together give you the whole picture for planning.
Got it. 3 pillars: DRE, MRI, CT.
Exactly. Now let's move forward. The patient's workup is complete. The CT of the chest, abdomen, and pelvis thankfully shows no evidence of distant metastatic disease.
Okay, good.
However, the MRI report provides some specific findings. The tumor is still at 7 centimeters from the anal verge, and it extends 6 millimeters through the muscularis propria into the mesorectal fat. The shortest distance from the tumor to the mesorectal fascia is 2 millimeters. Furthermore, the MRI identifies one suspicious 5 millimeter mesorectal lymph node. So based on these findings and using the American Joint Committee on Cancer, or AJCC 8th edition, what is his full clinical stage?
All right, let's break down his clinical stage using AJCC 8th. For the T stage, the MRI says the tumor extends 6 millimeters through the muscularis propria into the pericolorectal tissues, the mesorectal fat. That depth of invasion going beyond the muscularis propria clearly makes him a clinical T3. T1 is the mucosa, T2 is into muscularis propria, T3 is through it into the mesorectal fat, T4 would be into organs. So 6 millimeters into the fat is a definite CT3. For the end stage, the MRI identifies one suspicious 5 millimeter mesorectal node. In rectal cancer, 1 to 3 regional nodes makes him clinical N1. 4 or more would be N2. So with the single suspicious node, he's CN1. And for the M stage, the CT chest, abdomen, pelvis was negative for distant disease, so he's clinical M0. So putting it all together, his full clinical stage is T3N1M0. According to AJCC 8th, a T3N1M0 rectal cancer is classified as stage 3B disease.
That's correct. A very precise breakdown. And a critical teaching point here, something that often trips people up on boards. Remember that any N1 rectal cancer, even if it's a T1 or T2, automatically makes it stage 3.
Right. Node positivity means stage 3.
Exactly. Node positivity significantly impacts prognosis and dictates a more intensive treatment approach. Now, based on his clinical stage, T3N1M0, and specifically highlighting those MRI findings, that 2 millimeter distance to the fascia and the suspicious node, what are the key prognostic factors here, and what are the expected patterns of failure that will guide your treatment recommendation?
Okay, so given his stage and those specific MRI findings, 2 critical prognostic factors jump out, and they each point to different patterns of failure that we need to address. First, thinking about local recurrence risk. His threatened circumferential resection margin, the CRM, at 2 millimeters is a major immediate risk factor for local failure. The mesorectal fascia is that crucial oncologic boundary. When the tumor is this close, it makes it really challenging for surgeons to get a truly clear margin during the total mesorectal excision, the TME. It just raises the likelihood of leaving microscopic disease behind, which is a huge predictor of local recurrence if we don't tackle it preoperatively. 2 millimeters is definitely concerning.
Absolutely. That CRM is key locally.
Second, regarding distant recurrence risk. His node-positive status, being CN1, significantly bumps up his risk for distant metastases. Lymphatic spread is how these cancer cells tend to disseminate systemically. Involved regional nodes mean the cells have likely escaped the primary site, may be forming micrometastases elsewhere. The liver is the most common spot for rectal cancer mets, then the lungs. So his CN1 status demands systemic therapy to hit those presumed micromets, even if we can't see them on scans yet. So yeah, we've got a dual challenge, a local control issue with the threatened CRM, and a systemic issue because of the node.
Perfect. You've clearly laid out those competing risks we often see. So given these high-risk features, what are his overall treatment options and what's your definitive recommendation? And importantly, please cite the key clinical trials supporting your choice.
Right. Considering those high-risk features, the threatened CRM and the N1 status total neoadjuvant therapy, or TNT, is definitely the preferred approach. No question. The whole idea behind TNT is delivering both systemic chemo and radiation before surgery. We want to maximize tumor downstaging, boost the chance of a pathologic complete response, or PCR, and zap any micrometastases to improve both local control and distant disease-free survival.
Makes sense. So TNT. What are the main strategies within TNT?
Well, there are 2 main strategies, each backed by big trials. First is an induction, or chemo-first approach. Here, systemic chemo, usually FOLFOX or maybe CAPOX, comes first, then long-course chemoradiation, then surgery. The Protégé 2-3 trial is key here, showing improved 3-year disease-free survival with induction chemo before chemoradiation and surgery for locally advanced rectal cancer.
Okay, Protégé 23 for chemo first. What's the alternative?
The second strategy is consolidation, or a radiation therapy first approach. This usually means either short course radiation, like 25 gray in 5 fractions, or long course chemoradiation up front, followed by systemic chemo, then surgery. The Rapido trial is pivotal for this strategy. It showed improved disease-related treatment failure and lower distant metastasis rates with this more intense neoadjuvant approach compared to just standard long-course chemoradiation followed by surgery and adjuvant chemo.
Rapido for radiation first. Got it. So for this specific patient.
My definitive recommendation for him, especially with that threatened CRM, would be a consolidation radiation therapy first TNT approach, using long-course chemoradiation. Specifically, I'd recommend 54 gray of radiation in 27 fractions with concurrent oral capecitabine. Then follow that with 4 months of consolidation FOLFOX chemotherapy, and finally, his definitive surgery, the TME.
And the justification for radiation first here.
The justification is really about prioritizing the most immediate threat, that 2 mm threatened CRM. We need to maximize the chance of clearing that margin. Both the Oprah trial and the CAO-ARROW AIO-12 trial provided compelling evidence that a radiation-first approach, especially with long-course chemoradiation, gives the highest probability of achieving a pathologic complete response, a PCR, and PCR is strongly linked to excellent local control and better survival. By hitting it with radiation up front, we maximize the chances of downstaging the tumor, shrinking it away from the fascia, and making a clear surgical margin much more likely. While the FOLFOX is crucial for the distant risk from his N1 disease, the radiation-first strategy directly targets and maximizes the chance of clearing that threatened margin.
An outstanding, evidence-based recommendation, very well justified, that really shows high-level clinical thinking. And a key teaching pearl here, a common trap on boards. When you have competing risks like local versus distant, you must be ready to articulate precisely why you're prioritizing one over the other. Here, clearing that threatened CRM is absolutely paramount. It makes the radiation-first strategy the most defensible and clinically effective choice.
Makes sense. You have to weigh the risks and justify the priority.
Exactly. Now let's assume the patient proceeds with your recommended plan. Please outline the technical aspects of his radiation therapy, simulation, setup, modality volumes, and crucial OAR constraints.
Of course, technical aspects, precision and safety are key. First, simulation and setup. I'd position the patient prone on a belly board, head turned aside, arms above head, and leg bent. The belly board is crucial. It helps displace the small bowel out of the high-dose field, minimizing GI toxicity, both acute and chronic. He'd also need a full bladder and an empty rectum. A full bladder pushes the bowel up and away. An empty rectum ensures reproducible positioning day to day and minimizes dose to the rectal wall itself. Anal marker to identify the anal verge. CT with IV contrast scan from above the diaphragm to below pelvis, about 2 to 2.5 millimeter slices. Reproducibility is fundamental.
Prone belly board, full bladder, empty rectum. Standard, but important. What modality?
Modality. I'd use IMRT, employing a simultaneous integrated boost, or SIB. IMRT gives us that highly conformal dose delivery, shaping the dose precisely to the target while optimally sparing healthy tissues. The SIB technique is great because we can deliver different dose levels to different targets concurrently each day. It's efficient and might even enhance tumor control by hitting the higher risk areas harder.
Okay, now describe your volumes.
For the treatment volumes, I will use a layered approach, starting with the gross disease and expanding to cover areas of microscopic risk. First, I will contour the gross tumor volume, or GTV. This includes 2 components, the GTV of the primary tumor, which I will delineate based on its appearance on the fused MRI, and the GTV of the node, which is the PET-avid mesorectal node. Next, I will create the clinical target volume, or CTV, for the high-risk boost, which will receive a total dose of 54 gray. I will generate this volume by taking the GTV of the primary tumor and the GTV of the node and creating a margin around them. Superiorly and inferiorly, I will add a 1.5 to 2 centimeter margin. Radially, or in the transverse plane, This CTV must be anatomically defined to encompass the entire rectum and the full radial extent of the mesorectum at those specific vertebral levels. The rationale for including the entire mesorectum is that microscopic disease can be present anywhere within that fatty envelope. The volume must also include the presacral space, which is a known primary lymphatic drainage pathway. Finally, I will edit this high-risk CTV to respect natural barriers, trimming it off of any uninvolved bone, muscle, or air.
Okay, what about low-risk volume?
The elective clinical target volume, or CTV, which receives 45 grays, is designed to cover the gross tumor, the entire mesorectum, the presacral space, and the internal iliac and obturator nodal basins. I would delineate this volume systematically. Superiorly, the field would extend to the L5-S1 interspace, which also covers the bifurcation of the common iliac vessels. Inferiorly, I would extend the field to the pelvic floor, which is often described anatomically as the level where the mesorectal fat disappears, ensuring at least a 2 centimeter margin below the gross tumor. Anteriorly, the volume encompasses the entire mesorectum. A key consideration here is internal organ motion. To account for variable bladder and rectal filling, I would add a 1 to 1.5 centimeter margin into the posterior aspect of the bladder. Posteriorly, the field includes the entire presacral space, typically contoured as a 1 centimeter rind of tissue anterior to the sacrum. Laterally, the field extends a few millimeters beyond the levator ani muscles. To cover the internal iliac nodes, I would place a 7 millimeter margin around the internal iliac vessels and then trim this margin off of bone and uninvolved muscle to respect anatomical boundaries. Finally, for the planning target volume, or PTV, I would apply a uniform 0.5 centimeter margin to these final CTVs.
Okay, that's a solid IMRT plan. Now, for the boards, you always need a backup. Let's say, due to insurance denial or technical limitations, you cannot use IMRT. How would you justify appealing that decision? And if the appeal fails, how would you design a 3D conformal plan?
My first step would be to appeal the denial. I would justify the medical necessity of IMRT by citing evidence showing it significantly reduces the acute grade 3 or higher gastrointestinal and hematologic toxicity. While the RTOG 0822 trial for rectal cancer was technically negative, this was likely confounded by the high toxicity of the concurrent CAPOX chemotherapy used. I would point to stronger evidence from other pelvic sites, like the Parser trial in cervical cancer, which clearly demonstrated the benefit of IMRT in reducing bowel toxicity. This is the standard of care for sparing normal tissues. If the appeal were unsuccessful, I would proceed with a 3D conformal plan, likely using a 3 or 4 field technique, with the patient prone on a belly board with a full bladder to displace the small bowel. For the initial fields to 45 gray, I would design a posterior-anterior field and matched lateral fields. The posterior-anterior, or PA, field would extend superiorly to the L5-S1 interspace. Laterally, the borders would be 1.5 to 2 centimeters beyond the pelvic brim, ensuring at least a 1.5 centimeter margin on the iliac vessels. Inferiorly, the field would provide a 3 to 5 centimeter margin below the tumor bed, ensuring coverage down to the bottom of the obturator foramen. The lateral fields would match the superior and inferior borders. The posterior border would be placed about 1 centimeter behind the anterior surface of the sacrum to cover the presacral space. The anterior border would typically be placed just behind the pubic symphysis. After 45 gray, I would cone down for the boost. The boost field would cover the primary tumor bed with a 2 centimeter margin, ensuring coverage of the sacral hollow to bring the total dose to 50.4 gray.
A very thorough plan. You've clearly outlined the technical details for both IMRT and 3D conformal therapy. What about your organs at risk?
Absolutely critical. Organ at risk, or OAR, constraints. Strict quantifiable limits are a must. For the small bowel, my constraint would be V20 less than 150 cc. So, less than 150 cubic centimeters of small bowel gets 20 grays or more. Minimizing bowel dose prevents nasty enteritis. For the bladder, V35 should be less than 50%. Less than half of the bladder volume gets 35 grays or more, reducing cystitis risk. And for the femoral heads, V44 should be less than 5%. Less than 5% of the femoral head volume gets 44 grays or more, mitigating the risk of a vascular necrosis or fractures long term. These are well-established standard constraints demonstrating commitment to safety.
That is a very clear, comprehensive, and importantly, safe plan. Shows a strong grasp of the technical details. A vital teaching pearl here for boards. Always mention specific, quantifiable OAR constraints for the key organs, bowel, bladder, femoral heads. It really shows your commitment to safety and practical planning knowledge.
Right. Quantifiable constraints are essential to mention.
Definitely. Now, let's wrap up this case. The patient successfully completes all the therapy, chemoradiation, consolidation full Fox, TME surgery. Thinking long-term now, what are the potential long-term complications he might face from this aggressive treatment, and how would you anticipate managing them?
Yeah, addressing long-term complications is a huge part of counseling beforehand and follow-up afterwards. It can really impact quality of life. First, bowel dysfunction. He's at very high risk for low anterior resection syndrome, LARS. It's common and often debilitating urgency, frequency, incontinence, incomplete evacuation. It's from the combo of surgical disruption and nerve damage from surgery and radiation. My management would be multi-pronged. Proactive diet changes to find triggers, antidiarrheals like loperamide, and crucially, referral to pelvic floor physical therapy. Pelvic floor PT can be super effective in retraining bowel function and improving continence.
LARS is a big one. Management sounds comprehensive. What else?
Second, sexual dysfunction. Pelvic radiation and the TME surgery carry significant risk of damaging nerves and blood vessels needed for male sexual function, leading to erectile dysfunction, ED. I'd have a frank, empathetic talk with him about this pre-treatment, make sure he understands the risk. If issues pop up later, an early referral to urology is needed to discuss options, meds, devices, etc.
Important to counsel up front about ED, other radiation effects.
Third, other radiation therapy effects. There's a recognized long-term risk of pelvic insufficiency fractures, especially in the sacrum, due to radiation hitting bone density. I'd proactively recommend calcium and vitamin D. Tell him to report any new or persistent low back or hip pain. We also have to keep in mind the small but real long-term risk of secondary cancers in the radiation field, something we monitor for during surveillance.
Good points on fractures and secondary malignancies. What about chemo effects?
Finally, chemotherapy effects. Since he got FOLFOX, he's at risk for chronic, oxaliplatin-induced peripheral neuropathy, persistent numbness, tingling, pain, especially hands and feet. While acute neuropathy often gets better, some patients develop a chronic, sometimes debilitating form. Management is mainly supportive, symptom control. During treatment, we would have monitored carefully, maybe adjusted doses. Educating him about this is key.
Excellent. Covers the key long-term issues well. Great work on that comprehensive case. That really hit a lot of important points for locally advanced rectal cancer. Now, let's shift gears quite a bit, something different. Your next patient. She's a 62-year-old woman with a clinical T2N0, upper rectal adenocarcinoma. It's located at 11 centimeters from the anal verge. Her MRI reveals a widely clear circumferential resection margin measuring a comfortable 8 millimeters. 8 millimeters, okay. She's an excellent candidate for a sphincter-sparing low anterior resection, LAR, and critically, she expresses significant worry about the long-term side effects of pelvic radiation. Given her profile, is she a candidate for a radiation-sparing approach, and what are her treatment options you discussed?
Okay, yeah, that's a great setup for talking about de-escalation today. Based on her presentation, yes, she is an ideal candidate for a radiation-sparing approach, specifically thinking about the paradigm from the Prospect trial. She really ticks all the key boxes for inclusion in that study. First, her tumor is proficient MMR. Second, clinical stage T2N1. Third, it's an upper rectal location, 11 centimeters, well above the low rectal cutoff. And fourth, she has that widely clear CRM of 8 millimeters, way above the 3 millimeter threatened margin threshold. It all fits perfectly with Prospect's criteria.
So she fits the Prospect criteria nicely. How would you counsel her?
I'd have a detailed shared decision-making discussion, laying out two equally valid evidence-based options. Option one is the standard of care. Neoadjuvant, long-course chemoradiation, usually 50.4 gray with concurrent capecitabine or 5-FU, then her planned LAR surgery and potentially adjuvant chemo depending on final path. This is a long track record, very effective. Option two is the Prospect approach. This means starting with neoadjuvant chemotherapy first, specifically 6 cycles of FOLFOX. Under this protocol, pelvic radiation is reserved only for a suboptimal response to that initial chemo. Meaning, if her tumor shrinks well enough after the FOLFOX, she goes straight to surgery, potentially avoiding radiation completely.
And how do you frame that choice for her?
When counseling, I'd emphasize the prospect approach offers a greater than 90% chance of avoiding pelvic radiation and its lead toxicities, bowel issues, bladder problems, sexual dysfunction, which are her main concerns. But crucially, I'd also explain that this potential benefit comes at the cost of potentially higher acute chemo side effects during the full FOX neuropathy, nausea, fatigue, mucositis, compared to getting radiation up front. It's really a trade-off between acute chemo burden and avoiding long-term radiation effects.
Perfect. That's a textbook explanation of the prospect paradigm in patient counseling and a vital clinical pearl for boards. Know the specific inclusion and exclusion criteria for trials like Prospect. You nailed the inclusions. Key exclusions to remember are 4 tumors, clinical N2 disease, 4 or more nodes, a threatened CRM of 3 millimeters or less, and low rectal tumors, usually less than 5 centimeters from the verge. Those are generally higher risk locally, not great candidates for skipping radiation.
Right. T4, N2, threatened CRM, low rectal. Those are the exclusions.
Exactly. All right, let's move this case forward. The patient, concerned about radiation, elects the Prospect approach. She successfully completes 6 cycles of neoadjuvant FOLFOX. You get a restaging MRI, and it shows only 10% tumor regression. What's your recommendation now?
Okay, 10% regression. Well, my assessment is that unequivocally constitutes a suboptimal response. It falls below that 20% tumor regression threshold defined in the Prospect protocol as the cutoff for going straight to surgery. This suboptimal response strongly suggests that chemo alone might not be enough for local control, and the risk of local failure if we went straight to surgery now would be unacceptable.
So, suboptimal response, what's the next step per protocol?
My clear recommendation now is to proceed with the protocol-stipulated next step for suboptimal responders. Consolidative long-course chemoradiation. She'd get the standard 50.4 gray to the tumor and nodal volumes with concurrent chemo, probably oral capecitabine. Then after that, she'd have her previously planned TME surgery. This escalation back to chemoradiation is critical to ensure we adequately address the local disease, given the poor response to chemo alone, maximizing her chances of durable local control.
Correct. That's exactly what the Prospect protocol dictates for suboptimal response, ensuring necessary local therapy. So the patient completes this additional chemoradiation and then has her surgery. Final pathology from the TME shows 1 positive lymph node out of 22 resected. Given this whole picture, what are the expected results of her treatment, and what surveillance plan do you recommend?
Okay, so even though she needed all 3 modalities in the end, chemo, radiation, and surgery, her prognosis actually remains excellent based on the outcomes for this population in the Prospect trial. Regarding results and prognosis, the Prospect trial itself showed really favorable long-term outcomes, whether patients avoided radiation or got it for suboptimal response. Specifically, they reported about 80% 5-year disease-free survival and 90% 5-year overall survival for this population. Importantly, the local recurrence rate was super low, less than 2%. So even needing the extra radiation, her overall prognosis for long-term control and survival remains very strong, consistent with those trial results.
Excellent outcomes, even with the escalation. What about surveillance?
For surveillance, her follow-up should meticulously follow the NCCN guidelines for resected rectal cancer. Standardized approach is key. First, clinical visits and tumor markers. H&P exam and a CEA blood test every 3 to 6 months for the first 2 years. Then every 6 months for years 3 through 5. CEA is a great early warning sign, especially for systemic recurrence.
CEA and exams. Imaging.
Second, cross-sectional imaging. CT chest, abdomen, and pelvis every 6 to 12 months for 5 years. Vital for catching distant mets, especially liver and lungs.
And scopes.
Third, endoscopic surveillance, a full colonoscopy at 1 year post-op. Crucial to check the anastomosis, look for local recurrence, and screen for new, unrelated colon cancers, metachronous lesions. If that first scope is clear, then subsequent ones every 3 to 5 years per NCCN, assuming no new issues. This comprehensive plan maximizes chances of catching recurrence early.
Good work on that case. Showed clear understanding of de-escalation, managing responses, and follow-up. Thorough exploration there. Now let's move to something entirely different. A classic anal cancer case.
Okay, anal cancer.
Your third patient is a 64-year-old woman, presented to colorectal surgery for a chronic, non-healing anal fissure. Endoscopy and biopsy confirmed invasive squamous cell carcinoma. You're seeing her post-workup. DRE finds firm tissue at the left anal verge, normal sphincter tone. She's HIV negative, P16 positive. Imaging reveals a 2.5 centimeter tumor involving the internal anal sphincter with two equivocal 5 millimeter pararectal nodes. No evidence of distant disease. Based on the AJCC 9th edition, what's your clinical stage?
Okay, let's stage her using AJCC 9th for anal squamous cell cancers. First, T stage, tumor is 2.5 centimeters. AJCC 9th defines T2 as greater than 2 centimeters, but less than or equal to 5 centimeters, so 2.5 centimeters makes her a clinical T2. Internal sphincter involvement is clinically important, but doesn't change the T stage based on size alone here. End stage. Imaging shows two equivocal 5 millimeter pararectal nodes. Equivocal means suspicious but not definitively involved or pathologically confirmed. So with no definitively involved nodes on imaging, she's clinical N0.
So T2 is based on 2.5 centimeters in size, and N0 is based on equivocal findings. What about her M stage?
M stage, imaging shows no distant Mets, so clinical M0.
M0, overall stage.
Combining everything, her overall clinical stage is T2 N0 M0. According to AJCC 9th, that translates to stage 2A anal canal cancer.
Correct. Nicely done, especially picking up on the nuance of equivocal versus definitively involved nodes. Key distinction. Now, what's your definitive treatment recommendation for her stage 2A anal cancer? And critically, cite the key trials that establish this paradigm.
My definitive recommendation for her stage 2A anal cancer is definitive chemoradiation for organ preservation. This is absolutely the standard of care for any T2 or greater anal cancer. The main goal is cure while preserving sphincter function and avoiding a permanent colostomy.
Organ preservation chemoradiation. Tell me about the history and evidence.
Historically, the paradigm shifted dramatically away from upfront APR surgery. This huge shift was largely thanks to the foundational work of Dr. Norman Negro back in the early 70s. Dr. Negro showed that combining chemo and radiation could achieve high rates of PCR and anal SCC, curing the disease without radical surgery. This became known as the Negro Protocol and totally changed how we manage anal cancer.
Negro Protocol started it all. What solidified adding chemo?
The superiority of adding chemo to radiation was then nailed down by two landmark Level 1 trials. First, the UK CCCR Act 1 trial, published 1996, randomized radiation alone versus radiation plus concurrent 5-FU and mitomycin C. Second, the EORTC 22861 trial, also published 1996, similar comparison. Both trials definitively showed adding concurrent 5-FU and mitomycin C significantly improved local control and, crucially, colostomy-free survival compared to radiation alone. This unequivocally established chemoradiation as the primary curative sphincter-sparing approach. So today, surgery is really reserved for salvage, only if chemoradiation fails or disease persists.
Excellent. You hit the key history, Negro, and the Foundational Trials Act 1 and EORTC 22861, critical points for boards. Now, please outline your specific radiation prescription doses, volumes, and the concurrent chemo regimen.
Okay, based on her T2N0 stage and following modern guidelines, my recommendation would draw from the RTUG 0529 dose-painted IMRT approach and the updated 2025 ASTRO guidelines for radiation dose. For a T2N0, the prescription to the primary gross tumor volume would be 50.4 gray in 28 fractions. This aims for cure while prioritizing sphincter preservation. Simultaneously, the elective pelvic and inguinal nodal basins get 42 gray via SIB. Elective nodal coverage is essential. Anal SCC has predictable spread to inguinal, iliac, and pararectal nodes. SIB lets us deliver these different doses efficiently each day. Concurrent chemotherapy, the standard well-established regimen. Mitomycin C is given as a single dose 10 milligrams per meter squared on day 1 of radiation. It's a potent radiosensitizer, plus either continuous infusion 5-FU or oral capecitabine, given on radiation days, maybe days 1 to 5 of weeks 1 and 5, or continuous infusion over the whole course, depending on the institution. This combo acts synergistically with radiation to boost tumor kill and improve control rates. which is why those landmark trials proved its superiority.
Exactly right. Precise, guideline concordant plan covers all the bases. Now let's tackle a common, challenging acute toxicity. Say the patient is halfway through treatment and develops grade 2 moist desquamation in the perianal region. How do you assess and manage this to keep her on track?
Ah, yes, moist desquamation. Very common, very expected with anal cancer radiation, given the sensitive skin and high doses there. My approach would be proactive, aggressive, and supportive, aiming to ease discomfort, prevent worsening, and crucially avoid treatment breaks. First, thorough assessment. Document the grade and extent. Reassure the patient this is typical, anticipated, helps with coping.
Okay, assess and reassure. Management steps.
Management. Immediately prescribe a barrier cream. A great combo is a 1-to-1 mix of zinc oxide and bacitracin, or just Desitin works well. Apply liberally multiple times a day, especially after bowel movements, on clean, dry skin. Creates a barrier, reduces friction, promotes healing, eases pain. Third, strongly recommend sitz baths. Warm water baths for the perineum multiple times a day. Very soothing, gently cleanses, reduces pain and inflammation.
Barrier creams, sitz baths. What about pain?
Fourth, pain control. Prescribe topical lidocaine, a local anesthetic. Apply directly to the painful skin, gives immediate temporary relief, especially before bowel movements. If needed, oral analgesics, even narcotics would be prescribed.
And the main goal through all this?
The critical overarching goal is managing symptoms effectively and aggressively to prevent a treatment break. We know from pooled analysis of RTOG trials that even short breaks, just a few days, can compromise outcomes, potentially lowering local control due to tumor repopulation. So aggressive symptom management is paramount to keep the radiation schedule intact for the best outcome.
That's a perfect, clinically sound plan for managing this tough toxicity, emphasizing the crucial point about avoiding breaks. All right, let's tackle our final case. This is a complex one, a real curveball. Your final patient, 68-year-old woman, significant history, treated 15 years ago for cervical cancer with definitive chemoradiation, specifically 45 gray external beam plus brachytherapy to the pelvis.
Wow, okay, significant prior dose.
She now presents with a new diagnosis, a clinical T2N0 3-centimeter squamous cell carcinoma of the anal canal. Given her extensive prior pelvic radiation, what are her treatment options for this new anal cancer? How do you approach this?
Her prior radiation drastically changes everything. That 45 gray EBRT plus brachy 15 years ago is a major relative contraindication to standard care for her new anal cancer. The cumulative dose to her pelvic organs from standard anal cancer chemo added to her previous dose would be extraordinarily high. The risk of severe late toxicities would be almost prohibitive. Chronic pain, debilitating proctitis or cystitis, obstruction, fistulas. Re-irradiating to full curative doses here is incredibly dangerous.
So standard chemorad is likely off the table. What options remain for discussion at tumor board?
Her options need thorough, frank discussion at a multidisciplinary tumor board, carefully weighing risks and benefits. The primary options would be, first, and in my view, the leading option, an abdominoperineal resection, or APR. Generally the safest, most standard curative surgical approach in this re-irradiation setting. It removes the rectum and anus, means a permanent colostomy, but completely avoids any further pelvic radiation. Offers the best chance of cure with the lowest risk of severe treatment complications by bypassing that cumulative dose issue.
APR is the primary, safest curative option. Any non-surgical or sphincter-sparing possibilities?
Second, a highly specialized, less available option, interstitial brachytherapy. This could potentially offer sphincter preservation for a small T2 like hers. A localized high-dose implant might deliver concentrated dose to the tumor while theoretically minimizing dose to previously radiated tissues. However, this needs a highly experienced brachy team specializing in re-irradiation. Even then, risks of necrosis, chronic pain, fistula are still elevated, reserved for very select cases at specialized centers.
Brachytherapy as a specialized, risky alternative. What about external beam again?
Third, and generally a very high-risk option, careful re-irradiation with external beam radiation therapy, typically reserved only if she were absolutely inoperable due to other comorbidities, or if she adamantly refused surgery despite extensive counseling on the extreme risks. Even with fancy techniques like IMRT and meticulous planning, the risk of severe, acute, and late toxicities is substantial. It'd be a last resort, maybe with palliative intent or compromised dose due to the intolerable risk of severe complications.
So EBRT re-irradiation is a very last high-risk resort. Your primary recommendation?
Given the goal of cure with the lowest risk of severe, life-altering complications, my primary recommendation would be an upfront abdominoperineal resection. It offers the best shot at cure while avoiding the potentially devastating consequences of re-irradiating an already maxed-out pelvis. Patient education and shared decision-making are absolutely key here.
An excellent and safe recommendation. Thoughtfully considered, prioritizing safety in a very tough scenario. A vital teaching pearl in any re-irradiation case. Always identify surgery as the primary curative modality if possible. It often gives the best balance of control and toxicity, and critically, be able to discuss the extreme risks and specialized nature of any further radiation. Know when standard care is unsafe and pivot to the best alternative.
Absolutely. Surgery often becomes the go-to in re-irradiation if feasible.
This concludes our case-based review, and actually our entire GI oncology series for Rad-On Smart Review.
Wow, that was a really comprehensive set of cases. Covered a lot of ground in lower GI oncology.
Indeed. Today, we really solidified clinical reasoning, applying evidence to 4 comprehensive, board-style lower GI cases. We navigated TNT for high-risk rectal cancer, understanding how to prioritize competing risks, like a threatened CRM versus nodes. We identified a perfect candidate for radiation emission via prospect, and discussed escalating treatment when needed. We outlined standard care for classic anal cancer, and the key trials and technical aspects. And finally, we skillfully managed that complex cancer in a previously irradiated field, emphasizing safety and the role of surgery. The common theme throughout. Modern GI oncology demands sophisticated, risk-stratified, personalized, evidence-based, multidisciplinary care, meticulously tailoring treatment to the individual.
Yeah, the main principles I'm taking away from this whole series, and especially today's cases, are exactly that. The critical importance of a true multidisciplinary approach, the absolute necessity of applying trial evidence to individual patients, and needing to thoroughly understand both the benefits and toxicities of our treatments, always focusing on patient-centered care and quality of life. It really reinforces that radiation oncology, especially in these complex GI cases, is as much an art of balancing risks and making nuanced decisions as it is a science of delivering precise radiation.
Well said. That wraps up our case-based review of lower GI malignancies. Great job working through these scenarios and applying all that knowledge with such precision.
Thanks. This was incredibly helpful, definitely good for board prep, and just for thinking through how these complex cases really play out day to day.
Absolutely. For all of you listening, remember you can get detailed show notes and complete additional practice oral boards at radonsmartlearn.com. Be sure to subscribe to Rad-On Smart Review for our next series. We'll be tackling new and exciting topics in oncology. Thanks for tuning in.